Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at notes for extract 1. This is a Benchmark Education Solutions sample test paper. Extract 1. Questions 1 to 12. You hear a GP talking to a patient about recent weight loss. For questions 1 to 12, complete the note with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Jacobs. How are we doing today?
Okay, I suppose.
So I see here that you made the appointment because of recent weight loss. How much weight have you lost?
Approximately 10 kilograms in the past 4 months or so.
Okay, and I'm going to assume that this weight loss has not been intentional?
Oh no, I just haven't had much of an appetite, and I'm having an increasing issue with vomiting.
I see. And does your vomiting happen soon after eating?
No, it generally happens many hours after I have eaten.
And, are you experiencing any other changes in your health?
Yes. I live alone in a 2-floor house, and I have noticed over the last month that my legs feel weak when I go up the stairs or walk up a small hill near my house.
And I remember you telling me that 2 years ago you were prescribed beta blockers or hypertension. Are you still taking that medication?
Well, I stopped taking the beta blockers about 4 months ago.
Okay. Well, let's take a look at the investigations that you had done for this appointment. So I see that urea is out of the normal range, quite a bit higher, which suggests dehydration. That is to be expected because of the vomiting you just mentioned. And look here, your sodium and potassium levels are lower than I would expect. That is also likely due to the vomiting. The low potassium levels also likely explain the weakness you have been feeling. So you said that you vomit quite a bit of time after eating, correct?
Yes, that is correct. Several hours at least.
I'm afraid everything points to obstruction to stomach outflow. I can also hear a sloshing sound through my stethoscope, which suggests the presence of gas and fluid that are trapped inside the stomach.
So things can't go out, so they are coming back up.
That's one way to look at it.
But what could be blocking the food from leaving my stomach? I mean, that sounds quite serious.
Unfortunately, I cannot tell what the cause is from these investigations.
If the problem is in my stomach, wouldn't I be having stomach pain?
Depending on the cause of the obstruction, there would not necessarily be abdominal pain. So we will have to do a gastroscopy and biopsy to confirm the diagnosis and look for the cause of your problem. We could be looking at a chronic gastric ulcer or a tumour in the pyloric antrum, which is a part of your stomach near the bottom. But because of the retained food in your stomach, we will need to wash out your stomach to make sure we can see what is causing the obstruction of the outflow tract of the stomach.
This is a Benchmark Education Solutions sample test paper. Extract 2. Questions 13 to 24. You hear a doctor in the A&E talking with a patient with persistent headaches. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mr. Saunders. How are you today?
I am well, but please do call me Nathan.
OK. Nathan. So, I see here that you came into the hospital because of a number of problems, including a deterioration of vision of the past 3 days, reduced urinary output, and ankle swelling.
Yes, and the headaches. They are horrible. Before recently, I have never really had headaches, so it has been difficult for me.
So, exactly how long have you been experiencing these symptoms?
Well, the failing vision and all the rest of that. Just the past 2 to 3 days. But headaches have been going on for about 4 months. There is a constant throbbing, and simple analgesics are not working.
Have you seen a doctor for the headaches before today?
Oh yes, I went to my GP about 2 months ago. She said I had tension headaches and gave me codeine for it. But that didn't work either, so I went back to her a couple of weeks after that. So about 3 weeks ago now. She gave me another medication, but I don't remember the name of that.
And was that medication effective?
No, the headaches continued, and then about 3 days ago they became worse, and my vision went all blurry. That's when I also noticed that I wasn't really going to the bathroom that much, and also that my ankles were swelling.
So let's take your blood pressure. Oh my, your blood pressure is 190 over 140.
That's bad, isn't it?
Yes, it is. It is considered hypertensive crisis. Was your blood pressure measured when you went to the GP for the headaches?
Not that I can remember. I mean, if it was, my GP certainly didn't say anything at all about it being high.
I can also see that you have retinal hemorrhages and papilledema. This, along with what may be renal failure, points to accelerated hypertension. The most important thing right now is to lower your blood pressure at a gradual rate over the next 24 hours. Rapid reduction can be dangerous and can cause arterial thrombosis and problems in a number of organs. I'm going to order an IV of antihypertensive drugs. It is also necessary to control your fluid intake and keep you under observation for the onset of pulmonary oedema. We may also need to put you on dialysis due to the problem with your kidneys.
Dialysis? I mean, are my kidney problems that serious?
Well, if we notice the development of a pulmonary oedema, dialysis will be necessary because you will not respond to diuretics due to the problems with your kidneys. As to the severity of your renal failure, we don't know yet if the renal failure is chronic or acute or a mixture of both. The kidneys are being damaged by the hypertension, but at this point we don't know if they are chronically damaged or if there is some other undiagnosed renal disease. We will also do a renal ultrasound, which is quick and non-invasive, to be sure about the size of your kidneys.
What will the size of my kidney tell you?
Well, kidney atrophy or shrunken kidney would indicate a damaged kidney.
And what about my vision? Is this vision loss permanent or long-term?
I don't think so. Your impaired visual acuity should recover completely.
And what about my kidney? If there is damage, is it permanent?
Again, we'll have to wait and see about that. Your hypertension has been damaging your kidney function for several weeks now, so...
That is the end of Part A. Now, look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a training about patients in ICU wards. Now read the question. This is a Benchmark Education Solutions sample test paper.
So I'm here today to describe a problem our ward has been experiencing and some possible consequences of that problem. Then, later, we will talk about possible solutions. So the first problem I want to address is that we often find ourselves in the position of having more patients who require ICU admission than we have beds available, which results in an untimely admission. Untimely admissions are associated with a longer length of stay, more advanced respiratory support, and increased mortality rates. This problem is made worse by the fact that it is likely that many of our current patients could be transferred to another ward as they no longer require an ICU bed. These two factors come together to have a negative impact on the care of acutely ill patients, as they are often cared for by non-specialised staff, alongside the critical care outreach team. So another set of problems that we have observed is
Question 26. You hear a trainee doctor asking a senior doctor about next diagnostic steps. Now read the question.
Dr. Stevens, I wanted to ask you about the school teacher who came in with shortness of breath.
Yes, have you read the patient's medical history?
Yes, and I also saw the chest x-ray. I know that one of the most common causes of persistent dry cough in patients with a normal chest x-ray is asthma.
Yes, that is correct. What would you need to do next to see if that is the cause of this patient's problems?
Well, we would need to ask the patient to record her peak flow rate at home over the next couple of weeks.
Exactly, that is our next step.
Question 27. You hear part of a training about eating disorders. Now read the question.
I'm here today in order to address a problem in the field of medicine: the shocking lack of built-in training that exists for medical professionals on eating disorder service delivery. This lack of training is across the board, as even in psychiatric programs where you might imagine that would be a higher degree of attention paid, psychiatric residents often report feeling unprepared to face the realities of treating eating disorders in all of their complexities. In fact, a recent survey of medical training programs showed that less than 30% of general psychiatric programs offered rotations in eating disorders. The numbers are even lower in family medicine programs. GPs, psychiatrists, and doctors in pediatrics often act as key gatekeepers for eating disorder services, so it is important for them to be trained to address eating disorders. So today,
Question 28. You hear part of a training on safety briefings. Now read the question.
So today we are going to talk about the importance of regular ward safety briefings. Safety briefings in patient care units are tools to increase safety awareness among frontline staff and foster a culture of safety. Based on lessons from other industries, briefings make safety consciousness part of the routine 24 hours a day and 7 days a week. So now we are going to go over a few tips on how to conduct ward safety briefings. First, those giving the briefings should reinforce the non-punitive aspect of the discussion, and you should keep briefings short. Another tip is to adjust the frequency and time of day based on staff feedback, which should also be taken into account by collecting detailed information. Finally, it is recommended that you
Question 29. You hear part of a handover between two nurses. Now read the question.
So, how are you liking the afternoon shift?
It is okay. I feel like it is less hectic than the morning or night shift, but it has only been a few weeks. So why don't we go somewhere a bit more private to do the handover?
Sounds good. So the patient in room 105 has been having acute back pain for several days and was admitted early this morning. He was previously operated on last year for appendicitis. He has no other relevant medical history. He has been a bit drowsy today because of the pain medication he's on. The doctors have ordered a CT scan and we're still waiting for that to happen. I need you to...
Question 30. You hear a conversation between a GP and a psychiatrist. Now read the question.
So, Dr. Harold, I'm calling about the patient that I referred to you for treatment. I wanted to give you a complete picture of the patient's condition and what is being done to find a cause to his medical issues.
Great. I was just starting to take a look at the patient's file, so any context you can give me will be helpful.
And that is what I thought. So, as you can see in the file, the patient has gained over 10 kilograms in the past 6 months, and he reports being hungry constantly. The reason I referred him to you was because he reported feeling depressed and having trouble sleeping. He has had no previous psychiatric illnesses and did not report any relevant medical history.
Okay, so what are the next steps for him?
I have ordered investigations, which should let me see if there are any hormone imbalances or changes, and then based on those results, I will have to consider referring him to...
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear part of a presentation on training opportunities in dentistry. You now have 90 seconds to read questions 31 to 36. This is a benchmark education solution sample test paper.
So today I'm honoured to present Dr. Nijad, who is an internationally recognised specialist in restorative and aesthetic dentistry and who works tirelessly to inspire passion in the art and science of dentistry and mentor future generations of dentists to lead the profession. And Dr. Nijad will discuss the training opportunities available in these two areas of speciality. Please join me in welcoming Dr. Nijad.
Hello, everyone, and thank you very much for that kind introduction. I am indeed very passionate about inspiring and mentoring future generations of dentists, and a key part of that is promoting the understanding of the remarkable properties of the natural tooth, including aesthetics, function, strength, and biomechanics. I seek to promote these areas through taking an active role in scientific research, as well as developing and delivering advanced training courses for practicing dentists. As Dr. Sampson just mentioned, I'm going to talk about training courses in restorative and aesthetic dentistry. So first I'm going to talk about restorative dentistry. And the first thing to mention is the approach that we take, which is the biomimetic approach. Using this approach, course participants will learn how to preserve intact tooth structure while restoring teeth to function and restoring strength. I'm going to take just a moment to explain a bit of the difference between this approach and traditional dental procedures. Traditionally, dental procedures rely on preparation designs that accommodate the restorative material or technique. This includes preparation features such as retention and resistance form, as well as tooth reduction to meet the strength requirements of the restorative material, instead of prioritizing the preservation of intact tooth structure. And the result of this is that the restored tooth has significant additional preparation and a significantly higher chance of complications, such as post-op pain, sensitivity, root canal treatment, recession, as well as fracture. As I have already alluded to, the biomimetic approach unites an understanding and appreciation of the biomechanics of natural teeth with principles and techniques that maximize adhesion. The restorative materials used in this approach replicate the properties of the dental structure, and so healthy intact tooth structure is preserved through adhesion without additional preparation requirements. These materials also have increased bond strengths, which helps to eliminate the catastrophic failures often associated with traditional crowns and other procedures. The biomimetically restored tooth mimics the strength, functions, and aesthetics of natural teeth. The course that we offer in restorative dentistry starts with an introduction into the biomimetic treatment approach, including foundational concepts, principles, and the advantages of this approach, including how it can revolutionize the way you approach restorative dentistry in your own practice. From there, we will move on to a hands-on course that will cover everything you need to get started with biomimetic restorative dentistry in your practice. This course will include techniques and materials with an emphasis on posterior restorations. In addition to the introductory and hands-on courses that I just described, there is an advanced course in biomimetic restorative dentistry that includes an in-depth literature review of the core science of this approach, including a review of over 25 articles that cover a wide variety of related areas. These courses can be taken as standalone courses over a couple of days, or they can be bundled together into a complete training course delivered over the course of 1 week. The complete training course option includes additional training on scientific literature, as well as cases on adhesion, materials, structural analysis, and stress reduction. As a follow-up to these courses, we also offer in-office mentoring to help you implement these advanced techniques in your own practice. We find that our system of mentoring helps to give dentists the confidence to take that next step into restorative dentistry. So now I am going to move on to talk about our courses about aesthetic dentistry, which is a natural complement to restorative dentistry since it requires less accommodation, incorporates acceptable biologic technology to increase the probability of long-term survival, as well as to mimic the pristine state of the natural dentition. Just as I previously discussed with restorative dentistry, aesthetic dentistry stands in contrast to cosmetic dentistry, which does not always emulate the pristine state of natural dentition. So,
now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview about recent innovations in physiotherapy. You now have 90 seconds to read questions 37 to 42.
So today we have a special guest here to talk about innovations in the field of physiotherapy. I would like to welcome Sally Fields, a physiotherapist working with the NHS. Welcome, Sally.
thank you for having me. I'm so happy to be here today to share my passion with others.
So, before we get into innovations, I would like to talk about the role of physiotherapy in a person's overall health. So, how can it contribute to the health of the population?
That's a very good question. Physiotherapy takes a whole person approach to health and well-being. So with the population getting older and more people living with long-term conditions, it is necessary to use physiotherapy to help patients manage long-term medical conditions such as Parkinson's, asthma, cystic fibrosis and chronic obstructive pulmonary disease. Just to put the situation in perspective, 3 out of every 5 people in the UK have a long-term condition.
Oh, interesting. How is physiotherapy used to manage a disease like cystic fibrosis? I would never have thought of physiotherapy being used for that type of condition.
In the case of cystic fibrosis, regular physical activity and physiotherapy-led exercise help improve physical function, cardiovascular performance, and muscle strength. Exercise may also aid airway clearance, slow the rate of lung function decline, contribute to an improved quality of life. In general, physiotherapy helps to build resilience in patients by building their capacity to manage their own health. And it also helps to enable people to regain maximum levels of mobility, function, and independence following an accident or as they recover from an illness. Another interesting aspect of physiotherapy is the way it can be tailored to meet individuals' personal goals. Because physiotherapy requires a lot of commitment and effort on the part of the patient, establishing personal goals is very important.
Yes, it is definitely important for patients to play an active role in the management of a long-term condition.
Definitely, and that's why physiotherapists are starting to work alongside GPs. practice physiotherapists can help to assess, diagnose, treat, prescribe medicines, as well as manage patients' needs. This new model of care is part of a multi-pronged approach that has the potential to address the immediate crisis in general practice, as well as, of course, help deliver a better GP service as part of a modern primary care system.
Okay, so innovation in physiotherapy. What is the first innovation that you're going to talk to us about today?
Well, the first is robot-assisted physiotherapy. I will give a few examples of how it is used to give you a better idea of its current role and future potential. So, loss of arm function is a common problem after stroke, and there are ongoing clinical trials to determine to what degree robot-assisted training can help patients recover upper limb movement.
So is the robot replacing a physiotherapist?
Not at all. Using robots allow the therapist to get a greater understanding of the neuro-recovery process and also helps to build a rich stream of data that assists in ongoing patient diagnosis and customization of therapy.
Okay, I see. So can you give us an example of how it might work?
Of course. So, during robot-assisted training, the stroke patient sits at a table facing a computer screen and place their arm into the device. The therapist then asks the patient to undertake some arm exercises, such as moving between targets on the computer screen. If, let's say, the person is unable to move their arm, then the robot moves the patient's arm. But if the patient is able to initiate the movement, the robot provides adjustable levels of assistance to facilitate the person's arm movement, which helps the brain and arm to learn to work together again. As I said earlier, the clinical trials are currently being done on this type of robot-assisted physiotherapy, so there is a lot we still don't know about the potential of this therapy. Another type of robotic-assisted therapy uses what is called an exosuit, which is a robotic-powered exoskeleton used in people with weak or paralysed legs caused by stroke, spinal cord injury, as well as other neurological conditions.
An exoskeleton. So does that mean it goes over the body of the patient?
Exactly. It is placed over the legs to help with standing and walking. Specifically, it uses battery-powered motors to drive the legs. So the way it works when the patient is moving is as the person shifts their weight, sensors are activated that initiate steps, which can help the patient to relearn step patterns and weight shifts.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.